Good evening, everybody. Welcome to this episode of Diastolic Function Evaluation by none other than Dr. Debika Chatterjee. She is a senior consultant and HOD of Department of Non-Invasive Cardiology based at Calcutta at RNTI Institute of Cardiology. And many of you must have listened to her before, and I saw the appreciation which she got. Possibly, I told her a little bit, not the whole of it. So with this few words, let me have the honor of presenting Dr. Debika Chatterjee for her diastolic function evaluations. Dr. Debika, it's all yours.
Thank you so much for the kind introduction. And good evening, everybody. I welcome you to this session of diastology. Hope everybody is keeping fine with dose of vaccine. And let us pray we don't get the second wave. So let us start diastolic function evaluation parameters. Now, to start with, I will present a case with 60 years old obese male having history of hypertension, controlled hypertension for a few years. Now, complaining of progressive exertional dyspnea with fatigue. And on examination, we get bilateral ankle edema, hepatomegaly, and bilateral Krebs. So obviously, the diagnosis is congestive heart failure. The moment we get a patient of heart failure, we start thinking that it's systolic heart failure. So we do the echocardiogram and we see that LV is contracting very well. Ejection fraction is around 65 to 70% by modified Simpsons. There is no regional wall motion abnormality. Then why the patient is having heart failure? So we do the Doppler study. We rule out the left to right shunt, which might cause the shortness of breath. We rule out right heart pathology also. And then we see that he has diastolic dysfunction with elevated LV filling pressure. So this patient is in diastolic heart failure with preserved ejection fraction, or an entity called HEPF, which accounts for around 40 to 50% of all heart failure, responsible for significant morbidity, mortality, and recurrent hospitalization, and prognosis is as bad as systolic heart failure. So we need to know how to diagnose diastolic heart failure. Now, whenever we get a patient of heart failure, we need to address few questions like, does the patient truly have the HEPF, or his or her shortness of breath is due to some other cardiac or non-cardiac problem? We also need to know the line of management, the functional status of the patient for optimization of our unloading therapy. We need to know the prognosis for follow-up of the patient. Now, all these questions can be answered while assessing the patient's diastolic function by echocardiography, because echocardiography not only gives us the idea about structural problems associated with diastolic dysfunction, it also gives us the information about the functional problem or the hemodynamic changes which are associated with diastolic dysfunction, because it is the LV filling pressure which is responsible for a diastolic heart failure. The elevated LV filling pressure is the final common effect of diastolic dysfunction, which results in shortness of breath. And we must remember that elevated LV filling pressure is a marker of poor prognosis. And moreover, as per the latest AEC guidelines for evaluation of left ventricular diastolic function by echocardiography, the grading of diastolic dysfunction is based on the presence or absence of elevated LV filling pressure. So in our echo report, we not only mention about the presence of diastolic dysfunction, we also do mention about the status of LV filling pressure, whether it's normal or elevated, and this way we grade the diastolic dysfunction also. Now, few lines about the normal diastole in a patient. As we know, diastole is a phase of relaxation. It is the process by which heart returns to its relaxed state. It starts with aortic valve closure and it ends with mitral valve closure. Now, if we look at the phases of diastole, which is very much essential to understand the hemodynamic changes in the heart in diastolic dysfunction, you look, say the diastole starts with isothalamic relaxation phase, where there is active myocardial relaxation and elastic recoil due to removal of calcium ion from the troponin C, as a result of which the pressure of the ventricle goes down. And a time comes when the LV pressure is below the LA pressure and the mitral valve opens. Mitral valve opens and the early rapid filling starts. Early rapid filling phase starts with opening of the mitral valve. Now, around 80% of the filling of LV takes place during early rapid filling phase. If you look at the LV pressure curve, this is the rapid filling phase, and look at the mitral inflow pattern, which I am going to explain you later. The first wave is the E wave. It coincides with the early rapid filling phase of the LV pressure curve. Now, as the LV gets filled with the blood from the LA, the LV pressure gradually rises, and a time comes when the LV and the LA pressure equalizes. And there will be no more filling. There will be deceleration of the blood because there is no positive force to push the blood. So the blood flow comes down, as you can see, and that phase we call as diastasis. Now remember, the 20% of the blood still in the left atrium. So that 20% of the blood is pushed from the left atrium to the left ventricle by active atrial contraction, or we call it atrial boost or atrial pump. So the A wave, which is due to the atrial booster, coincides with this part of the LV pressure curve. So if we look at all the phases of diastole, there are basically two factors which are responsible for the diastolic feeling of the ventricle. One is the relaxation and another is the compliance. Relaxation, I have already explained you, and it is the ability of the myocardium to relax during diastole because of the removal of the calcium ion. And another is the compliance, which is ability of the myocardium to accept a volume of the blood. As the blood goes from the LA to LV, the LV should be in a position to receive the blood. So basically, compliance is the change in volume in response to pressure. So if both these factors are behaving normally in a person, in normal diastole, there will be adequate LV filling without increased filling pressure, both at rest as well as at exercise. However, when there is impaired relaxation or reduced compliance of the LV due to stiffness, due to various diseases involving the myocardium, there will be impairment of the LV filling in diastole, and that will increase the LV filling pressure for a given volume, resulting in increased LA pressure with LA remodeling, which will result in pulmonary venous hypertension, and patient develops shortness of breath and goes into diastolic heart failure. There are various causes of diastolic dysfunction starting from the old age. As you know, at old age, various changes, structural changes take place in the heart as well as in the vascular system. There is impaired relaxation in old age, and the patient develops some amount of diastolic dysfunction as the age advances. So we must remember that impaired relaxation in an aged patient is not equivalent to the impaired relaxation in a young boy or girl. So a normal finding of impaired relaxation at old age must be remembered. A long-standing hypertension is another cause. Cardiomyopathy of different types like hypertrophic, restrictive, infiltrative, because the myocardium cannot relax in these disease processes. Also the coronary artery disease, where the myocardium becomes scarred or ischemic that cannot relax. Extensive cause like constrictive pericarditis may give rise to the diastolic dysfunction. So also obesity and the sleep apnea. Now there are various echocardiographic parameters or techniques by which we analyze the diastolic function in all these disease processes. So also in the normal patient. So one such is two-dimensional echocardiography. If you look at two-dimensional echocardiographic parameters, so these structural changes which we notice in different disease processes are objective evidence of diastolic dysfunction. This is a case of hypertrophic cardiomyopathy. As you can see, there is asymmetrical septal hypertrophy. These will give us an idea that this patient might be having diastolic dysfunction. So it helps us to differentiate between a normal and abnormal diastolic function. So also this case where there is a large area of LAD infarction at the LV apex, scarred myocardium cannot relax, as we know. So this patient will have some amount of diastolic dysfunction. Now, out of all these two-dimensional echocardiographic parameters, an important two-dimensional parameter is the enlarged left atrium, which we must remember because it is the robust indicator of diastolic dysfunction with elevated LV filling pressure. It is a chronic marker of raised LV filling pressure. Chronically raised LV filling pressure is reflected as enlarged atrium. Just like glycosylated hemoglobin in diabetes, enlarged LA is equivalent to long-standing diastolic dysfunction. And of course, in absence of anemia, atrial fibrillation, mitral valve disease, and also in athletes where we get enlarged LA. Now the question is, how do we measure the left atrium? We have a habit to measure the left atrium from the parasternal long axis. Yes, we do so. And we measure it from the inner edge to the leading edge, trailing edge to the leading edge in two-dimensional parasternal long axis view. And this is the normal diameter, linear dimension of left atrium. Now, you must remember that left atrium is a chamber. This is the anteroposterior diameter only, but left atrium also has a medial to lateral diameter, so also the superior to inferior diameter, because it's a chamber, it's a three-dimensional structure. So it may so happen that patient may have a normal anteroposterior diameter, but the left atrium is increasing in the medial to lateral aspect or in the superior to inferior aspect. So as per the latest AC guideline, this anteroposterior linear dimension should not be used as the sole measure of left atrial size. Look for LA volume, and that we should index to the body surface area. So how do we measure the LA volume? We measure from two views. It's a biplane aerial length method. So one such view is the apical 4-chamber, the other is the apical 2-chamber view. Now, in the apical four-chamber view, we freeze the image, then we scroll back to the end systole, just 1 or 2 frames before the mitral valve opens. So that left atrium is in its maximum volume. And we measure, we trace the endocardial margin of the left atrium, starting from septal annulus, go round and round and round, round and round to the lateral annulus. And we don't join these 2 points. Machine automatically joins these 2 points. Then we measure the length of this chamber. So we get area 1 and 1 length. And then we go to the apical 2-chamber view. Again, we repeat this procedure where we get the area 2 of the left atrium in the apical 2-chamber, and also we get a length. Now, so area 1, area 2, and out of these 2 lengths, we will take the value of shorter length. Like if this is 5 centimeter and this one is 4.9 centimeter, I will take 4.9 centimeter in my calculation. Now, we must remember that while measuring the length, the difference should not be more than 10%. If the difference is more than 10%, you should recalculate the entire thing. Now, so we utilize this formula of 0.85 into area 1 into area 2 divided by shorter length to calculate the LA volume, and we get a value. We index that value to the body surface area of the patient from the body weight and the height. Now, the upper limit of a normal value as per the latest AAC guideline is 34 ml per square meter body surface area. This is not very difficult, very easy to do. So you all should start practicing how to measure the LA volume from the apical 2-chamber and 3-chamber views. Now, after that, let us go to the Doppler parameter. After the 2-dimensional echocardiographic parameters, let us move to the Doppler pattern, where we look at the mitral inflow pattern for assessment of diastolic function. Now, what we do, we go to the apical 4-chamber view, put the color flow, and then the cursor is placed across the mitral valve, and the sample volume is kept at the level of the tip of the mitral valve leaflets in open condition. So this is the level of keeping the sample volume, and we get the pulse wave Doppler. Now, as you know, I have already shown you in normal diastole, normally the first wave is called E and the second wave is A, and E is more than A. So this is the normal pattern. E is more than A wave. Now, as the patient develops relaxation abnormality, the E wave velocity is reduced because LV pressure fall is less. So the pressure difference between the LA and LV is less. So amount of the blood flowing to the LV from LA is less due to the pressure difference. And the rest of the filling takes place during atrial pump. So A is more than the E wave. Now, the 80% of the filling which was taking place during the early rapid filling phase now is taking place during late rapid filling phase. Now, if this patient goes into atrial fibrillation, where atrial pump will be abolished, the patient goes into failure, depends entirely on the E wave for the LV filling. So we should be very, very, very careful regarding the atrial fibrillation of these patients. Now, once the impaired relaxation pattern is established and the diastolic dysfunction advances, what happens? The left atrial pressure starts rising. As the left atrial pressure rises, the E wave again becomes more than the A wave. As you can see, the left atrial pressure rise is causing the increased velocity of the E wave. Impaired relaxation pattern is still there. On top of that, since the LA pressure is rising moderately in this phase, E wave is increased. Now, as the diastolic dysfunction advances further and the LV becomes non-compliant, as I told you already about the compliance, what happens? LA pressure significantly rises. So that results in very tall E wave. And since LV is non-compliant, so LV pressure rise is very quick. So there is quick deceleration, so short deceleration time. And the A wave also is small, though the LA pressure is significantly high. But remember that LV is non-compliant. So LA is not been able to push the entire amount of the blood to the LV, so resulting in shorter A wave. So these are the signs of restrictive filling pattern: tall E, small a, short deceleration time. So we must remember that relaxation abnormality is present in this phase as well as in this pattern. It is because of the raised LA pressure and also the non-compliance of the LV, the pattern is changed. Now, if you look at this pseudo-normal and the normal pattern, they look so similar. So similar, E is more than A, as happens in this case. See, this is a patient who is who has come for a routine checkup, and we do the assessment of the diastolic function of the mitral valve, and we see that E wave is more than the A wave. On the contrary, look at this patient. This is a patient of hypertrophic cardiomyopathy. Look at the interventricular septum, how thick it is. So asymmetrical septal hypertrophy. Look at the left atrium, it's huge. And we are getting a pattern where again E wave is more than the A wave. Now we don't know which one is normal and which one is pseudo-normal. How do we differentiate between these two patterns? There are two methods. One is the Valsalva maneuver, another is the tissue Doppler imaging of the mitral annulus. So in the Valsalva maneuver, we reduce the preload by asking the patient to do a forceful expiration with closed mouth and nose. And the second one is tissue Doppler imaging. I'm going to show you one by one. Now let us see what happens to this patient who has come for a heart checkup, and I get a pattern where E wave is more than the A wave. I ask the patient to do I start tracing the pulse wave Doppler of the mitral inflow from here, and then ask the patient to do the Valsalva. As he does so, from here he has started doing Valsalva. Look at the flow pattern. Look at the E and the A wave. Velocity of both E and A waves are reduced proportionately so that E by A ratio remains normal. So this has to be a normal filling pattern. See, E wave velocity is reduced, so also the A wave velocity here also. On the contrary, look at this patient of hypertrophic cardiomyopathy. Look here. In this patient also we got E wave more than the A wave. However, when this patient does the Valsalva maneuver, the E wave becomes smaller than the A wave. So the impaired relaxation pattern is unmasked in this patient due to the reduction of preload by Valsalva maneuver. So this has to be a pseudo-normal filling pattern. So this is one of the ways how we differentiate between normal and pseudo-normal. And the second method is mitral annular velocity by doing tissue Doppler imaging. Now, what is tissue Doppler imaging? In the machine, you must have seen there is a button for tissue Doppler imaging. As we switch on that button, it colorizes the entire heart, tissues of the heart. So long we were measuring the velocity of the blood cells. Now we will measure the velocity of the tissue. Now, which tissue? In case of the assessment of diastolic dysfunction, it is the mitral annulus. Look, this is the mitral valve, this anterior mitral leaflet and the posterior mitral leaflet. This is called the septal annulus, and this is the lateral annulus. We get a thin slice, so annulus looks like this. Now, while doing tissue Doppler imaging and getting the velocity of the annulus, we always reduce the width of the sector, colorizing sector, because it is by reducing the width that we get a very high frame rate, which is very much needed for assessment of velocity in tissue Doppler imaging. Look, this is the septal annulus. So now what I'll do, I'll place the cursor here and keep the sample volume in the septal annulus first, and then again in the lateral annulus. So here it is the septal annulus, and I get the pulse wave Doppler. As I do so, I get some waves above the baseline and some waves below the baseline, as you can see. So what happens to the annulus during the cardiac cycles? See, during systole, the mitral annulus moves towards the apex, and during diastole, it moves away from the apex. So above the baseline, all the waves are systolic waves. Let us look at below the baseline, which are the diastolic waves. Now, the first major diastolic wave is called the E prime, and the second diastolic wave is called the A prime. Look at the septal annulus. It is the E prime and the A prime. Now, what is the normal velocity of septal E prime? It is more than 10 centimeter per second. So in this case, I got 12 centimeter per second, a normal value. So also in the lateral annulus, I move my sector to the lateral side after reducing it, and I get the velocity, and E prime at the lateral annulus is 14 centimeter per second. So this is the normal pattern. So E prime is more than A prime, both at the septal annulus and the lateral annulus normally. So let us see what happened to those two patients, one normal pattern and one pseudo-normal pattern. Here is the normal patient who came for a heart checkup. E wave was more than A wave, and I do the tissue Doppler imaging of the septal annulus. I get E prime more than A prime. So it is reflected in the tissue Doppler imaging also. E wave was more than A wave, so also E prime is more than the A prime, both at the septal annulus as well as at the lateral annulus. So this is a normal filling pattern. In pulse wave Doppler, E wave is more than the A wave. So also in the tissue Doppler imaging, velocity E prime is more than the A prime, both at the septal annulus as well as at the lateral annulus. Now let us look at the second patient of hypertrophic cardiomyopathy, where we again got this pattern where E wave was more than the A wave. We do the tissue Doppler imaging of the septal annulus, and what we see, you see, E prime is less than the A prime, both at the septal annulus as well as the lateral annulus. So tissue Doppler imaging will never let you down. It gives the actual picture, like E prime is less than the A prime in both the septal annulus as well as lateral annulus. Though in pulse wave Doppler of mitral inflow, we got E wave more than the A wave, but tissue Doppler gave the actual picture where E prime is less than the A prime, because the raised LA pressure tissue Doppler imaging does not get affected by the raised LA pressure. Now, When I talk to you about the tissue Doppler imaging, I must mention about a very important value called ratio of E by E prime. This value is important because it predicts the LV filling pressure. Now let us see how do we do that. So first we do the pulse wave Doppler of the mitral filling. We get E wave and A wave. We take the velocity of the E wave. Then we go to the tissue Doppler imaging. We do the tissue Doppler imaging of the septal annulus, where we get E prime and A prime. So we take the ratio of E by E prime at the septal annulus. Here it is around 24.75. If we calculate the E velocity to the ratio of E wave to the E prime, we get a value of 24.75. Then we proceed to the lateral annulus. Again, we get another value of E prime, which is here 0.06 meter per second, and E by E prime is 15.50. And we take the average of these two values, and we get around 20.12 average E by E prime in this patient. Now, what does it indicate? It indicates a very high LV filling pressure, because as per the latest AC guideline, if you get an average E by E prime value more than or equal to 14, it always predicts raised LV filling pressure. So we must remember that how do we do the E by E prime and what is the value. Now, tear jet velocity also indicates status of LV filling pressure. As you know, we go to the four chamber view, we get the tear velocity, you get the tear jet with color flow, and do the CW Doppler across the tricuspid valve. This is the tricuspid valve, this is mitral valve, and I get the tear jet below the baseline, and I measure the velocity. See, normal tear jet velocity is less than or equal to 2.8 meter per second. Here it is 3.15 meter per second. Now, if in absence of RV outflow tract obstruction, these will indicate the RV pressure difference between RV and RA. And if we add the RA pressure to it, it will give RV systolic pressure, which is same as pulmonary arterial systolic pressure. So in this case, IVC was dilated, so we add a value of around 8. So it is 39 plus 8. The PA pressure was high. So patient didn't have any lung disease. So in absence of that, this indicates that patient had a high LV filling pressure. So raised pulmonary arterial systolic pressure from the peak tear jet indicates elevated LV filling pressure. So after knowing all these criteria, let us go to the flow chart given by the AEC in its latest guidelines for grading of diastolic dysfunction in the patients with myocardial disease, either with normal ejection fraction or reduced ejection fraction. So now let us look. Just by looking at the mitral inflow, in some situations, we can classify the grade of diastolic dysfunction and the LV filling pressure. Not always, in some cases, as I said. So if your E by A ratio is less than or equal to 0.8 plus E wave velocity less than or equal to 50 centimeter per second, as happened in this case, who is a case of hypertension. As you can see, there is some hypertrophy, mild hypertrophy of the left ventricle. He has been treated for hypertension, and we get a pulse wave Doppler of the mitral inflow. We see that E is less than A, where E wave velocity is 48 centimeter per second, and EA ratio is 0.6. So a patient of hypertension having some myocardial disease with a normal EF in this case, if you get a pattern like this where E wave velocity is less than 50 centimeter per second and EA ratio less than 0.8, we say that LV filling pressure is normal or low, and we label this as grade 1 diastolic dysfunction. Clear? And let us look at the extreme right arm of this flow chart. Look at the mitral inflow. If your E by A ratio is more than 2, as in this case, look, this is a patient of cardiac amyloidosis. Look at the atria, both are enlarged. Look at the myocardium, thickened walls of the left ventricle, and I get a pattern where E wave is very tall and A wave is very small with EA ratio 6.6. So it is a patient having myocardial disease with reduced ejection fraction, of course, and a EA ratio 6.6. So as per the latest AC guideline, if you get a pattern like this, we say that LV filling pressure is elevated, and we grade it as grade 3 diastolic dysfunction. Without any parameters, we can say it's a grade 3 diastolic dysfunction having very high LV filling pressure. But we must remember that this patient should have a myocardial disease, either with normal or reduced ejection fraction. You may get normally this type of a filling pattern in healthy young individuals having normal LV ejection fraction, tall E, small a, because of high elastic recoil and very good relaxation. You may get a pattern like this normally in a healthy young individual. So don't consider in those cases that the patient is having grade 3 diastolic dysfunction. It is only in presence of myocardial disease with either with normal or reduced ejection fraction. But there are situations where only by looking at the mitral inflow, we may not be able to say that patient is having which grade of diastolic dysfunction, or whether the patient is having elevated LV filling pressure. What are the situations? Here, the EA ratio less than 0.8 plus EOF velocity more than 50 centimeter per second, or if EA ratio is more than 0.8 but less than 2, as in these cases. See, this is a case of hypertrophic cardiomyopathy. Though I am getting E wave less than the A wave, but here the E wave velocity is more than 50 centimeter per second. It's 99 centimeter per second, and EA ratio is 0.9. So it's fulfilling the criteria of this situation 1. Here we cannot say whether the LV filling pressure is elevated or not. So we cannot grade the diastolic dysfunction only by looking at the mitral flow pattern. In this case, we need additional parameters to comment on the LV filling pressure and the grade of diastolic dysfunction. This is the situation 1. And the situation 2, look here. This is a case of anteroseptal MI where there is large area of infarction with reduced ejection fraction, and EA ratio is 1.38. So it's falling in this situation where EA ratio is more than 0.8 but less than 2. Here also uncertain LV filling pressure and grade of diastolic dysfunction. We need some other additional criteria or parameters to comment on the LV filling pressure and the grade of diastolic dysfunction. What are those parameters? Let us look. There are 3 criteria to be evaluated. One is average E by E prime, which should be more than 14. I have already explained you how to calculate it. Next is the tear jet velocity. If it is more than 2.8 meter per second, it's a positive criteria. So also the LA volume index, if it is more than 34 ml per square meter, it is a positive criteria. Now, out of these three criteria, if you happen to get all three criteria in a patient and 2 out of 3 criteria or all three are negative, not fulfilling the values, then we say it is a grade 1 diastolic dysfunction, LV filling pressure. If 2 or all 3 are positive, then we say it is a grade 2 diastolic dysfunction with raised LV filling pressure. But sometimes we are not very lucky to get all 3 criteria. There may be, the patient might not be having tricuspid regurgitation. You only get 2 criteria for evaluation. So what do we do then? Out of those 2 criteria, if both are negative, we say it's grade 1 diastolic dysfunction. If both are positive, we say it's grade 2 diastolic dysfunction. And if one positive and one negative, we are not in a position to comment on the LV filling pressure and the grade of diastolic dysfunction. So what do we do in these cases? We look for some other additional parameters like isovolumic relaxation time. So what is that? As you know from your knowledge of diastology, diastole, normal diastole, it is the time between the aortic valve closure and the mitral valve opening, where LV myocardium undergoes relaxation. So its normal value by echocardiography is less than 70 milliseconds. How do we do that? We go to the apical 5-chamber view. As you can see, this is the mitral valve and this is the aortic valve. So LVOT is here. Now we will get the cursor and place the sample volume in between the mitral valve and the aortic valve and get the pulse wave Doppler. As we do so, it senses both the mitral inflow and the LV outflow. Look here, this is the flow pattern. Above the baseline is the mitral inflow and below the baseline is the LV outflow tract. Now we know the isovolumic relaxation time is the time between aortic valve closure. Here is the aortic flow and it ends here. So from here and till the mitral valve opens. So this is the time which is known as isovolumic relaxation time, and we measure in the echocardiography looking at the spectral pattern and the time between the aortic valve closure and the mitral valve opening, because E wave, this is the beginning of the mitral flow. So mitral valve opens here, and look here, IVRT is 66 millisecond. What is the normal value? It is less than 70 millisecond. Now remember that it has got inverse relationship with the LV filling pressure. The isovolumic relaxation time gets prolonged in the diastolic dysfunction with normal LV filling pressure, and it shortens in the diastolic dysfunction with raised LV filling pressure. So if it is very short, the LV filling pressure is high. So in grade 3 diastolic dysfunction, the isovolumic relaxation time is very shortened, whereas in grade 1 diastolic dysfunction, where there is LA pressure normal, the IVRT gets prolonged. We have problem of assessment of diastolic dysfunction in atrial fibrillation, where we can use this criteria. So less than 65 millisecond of IVRT in presence of atrial fibrillation indicates raised LV filling pressure. All these the values are taken from the latest AC guidelines. But we always have a challenge of measuring the IVRT. Yeah, if the patient has the tachycardia, this normally gets shortened, IVRT gets shortened. So in presence of tachycardia, we cannot rely on this parameter. Now, what are the other parameters? Another is the pulmonary venous flow pattern. So this is a normal heart. Pulmonary venous flow pattern assessment is difficult because pulmonary venous veins are in the far field. However, with the present day machines, it's not very difficult. As you can see, this is the left atrium, left ventricle, and this red flow is the right upper pulmonary vein. So what we do, we get the cursor and place the sample volume of the cursor deep inside the pulmonary vein, at least 2 centimeter, and get the pulse wave Doppler. Normally, there are 3 waves, one systolic, one diastolic, and a flow reversal. Flow reversal is during the late rapid filling phase when the atrium contracts. The most of the flow goes to the LV, but some flow goes back to the pulmonary vein, giving a backflow. So this is called atrial flow reversal. Anyway, let us look at the systolic and diastolic flow. Look at the ratio. In a normal patient, normal person, systolic wave is more than the diastolic wave. But in a case of myocardial disease with reduced ejection fraction, as in this case of anteroseptal MI, where where we couldn't get all the criteria, and so we took the help of pulmonary pattern. Look at the ECG, the systole is here, diastole is here. So systolic wave is less than the diastolic wave. So this indicates that patient is having high LV filling pressure. However, the pulmonary venous flow imaging is a challenge because in some patients we get suboptimal image where it is really a challenge. But must remember that it is not applicable in a healthy young individual with normal ejection fraction. It has to be reduced ejection fraction. The third criteria or the parameter is the color mmode propagation velocity, or called VP. Now, so long with the color flow, we were measuring the velocity by pulse wave Doppler. But now what we'll do, we'll get an apical four chamber with the color flow, a proper apical four chamber, and the cursor should be absolutely parallel to the mitral inflow. And instead of pulse wave Doppler, we are doing M-mode pattern. You see, as we do the M-mode, we get a pattern like this. So what we are going to see with the color M-mode propagation velocity? Basically, we will see how fast the blood is moving from base of the ventricle to the apex. So how fast the blood is propagating. We will pick up that with the help of M-mode. So what do you do? We get the M-mode. Look here, you can see the whitish lines. This is the level where the mitral valve is opening, and this is the M-mode pattern. Now we will look at the slope to comment on the propagation velocity. So what we do? We look at with the slope caliper. We fix one point at the level of the mitral valve, and the second point at 4 centimeter depth. Following this slope at the 4 centimeter depth, we measure the slope. So this PP, which is expressed in centimeter per second, normally is more than 50. But in all other grades of diastolic dysfunction, it is less than 50. So you cannot differentiate whether it's grade 1, grade 2, or grade 3. However, you can comment whether it's a normal slope or it is reduced. So if In a normal heart, where elastic recoil is very, very efficient, the blood flows very fast from base to apex. So this slope is very steep normally. And when the patient develops diastolic dysfunction, the slope becomes inclined. Now, it has got a low feasibility and reproducibility, no doubt about it, but we can always do it. And E wave of mitral inflow pattern by VP more than 1.4 predicts raised LV filling pressure and increased systolic volume.
Hello.